Hi everyone. Apologies for the delay. So who have we got online? So let me just check. We've got Jennifer, got Rebecca and Wendy. So hi there. Can I just confirm all of you attended the last session? I just want to check. Yeah.
Yes. Yep.
Fabulous. Feel free. There's only us. Feel free to take yourself off mute. Stick your hand up whenever you want and join in the conversation. So tonight is our second coaching session, and the purpose of tonight is to look at our problem statements and how we translate those into a specific aim that will help drive quality improvement. But before I do the introductions, I'd like to acknowledge traditional custodians of the land on which we meet and the many different nations across the regions. We pay our respects to elders past, present and emerging as the holders of the memories, the traditions, the culture, spiritual well-being of First Nations people. We recognise their continuing connection to land, water, culture and community. We acknowledge any sorry business that may be affecting communities as a whole. And in the spirits of reconciliation, partnership and mutual respect, we will continue to work together with Aboriginal and Torres Strait Islander peoples to shape a health system which better responds to the needs and aspirations of the community. So before we go any further, I'm mindful of the fact that some of you won't necessarily have met Jack before. So Jack, would you like to do a quick introduction? Mute, $20.
Oh, what a great start to the year. Oh, I'm out of practice. Hi, everyone. Nice to meet you. My name is Jag Dhaliwal. I'm a GP in the lovely Dandenong Hills here in Melbourne. And I've been working with Angie Parish for about 4 or 5 years now. So I'm originally from the UK, GP with interest in service improvement, and have done a variety of things looking at service improvement in the NHS and also internationally as well in Latin America and in Asia. And I've also worked around medico-legal risk management education. So very pleased to be part of this and pleased to be supporting as a tutor on this course. Thanks, Ange.
Thank you. And given we've got a small number tonight, I'm going to invite our participants to introduce themselves to you. So I'll start at the bottom of my list. Wendy, do you mind just explaining who you are, what you do, where you're from, and why you're interested in this? What's your motivations?
I'm a dietitian on Barkindji country, far west New South Wales at an Aboriginal medical service, but I tend to have quite a broad role and might sit in when the diabetes educator is not available or help with coordinating a range of appointments for patients. A large part of my interest in this project is trying to work out how we can actually get patients to come to appointments with allied health professionals other than podiatrists. So with the diabetes educator or myself.
Yep.
That's brilliant. Thanks, Wendy. God, yeah, patient engagement. Yeah, that's massive, isn't it?
Yeah.
Yes, it really is where we are. There, we have lots of services available for them, but getting them to come along is quite a challenge.
Yeah.
Thank you, Wendy. Yeah. Right, so next one on the list, Rebecca.
Hi, I'm Rebecca. I work with Western New South Wales Local Health District. I'm in an integrated care coordinator position. I'm based in Orange. And I came along mainly for curiosity and to look at how I can develop, I guess, a system around how I work with type 2 patients who have type 2 diabetes. I think working in a role like mine, where a lot of the time I'm working quite independently and in isolation from other services, I can get a bit lost with what it is people need to know, and also the challenge is to make sure that the messages I'm giving people are consistent with what they're being given by other health professionals, particularly people with more expertise in the area than me. So that's what I'm sort of looking at, is how I can standardise my practice to make sure it's aligned to primary health practice and evidence-based, so that I feel more confident in actually talking to people about their diabetes.
Wonderful.
Excellent. Thank you. Jennifer, I'll go to you next, and then I'll come to Heather and Helen.
I got the right button. I'm just driving home from Dan's drop-off. So I'm Jennifer Richmond. I'm a credentialed diabetes educator living in Cowra. So I work part-time in a general practice. I'm the only educator in town, so it's a bit isolating. You've got no one to bounce ideas off.
I think we've lost you, Jennifer.
Going through a tunnel.
Yes. In that wide open space. She's going through a tunnel. Sorry, we can't hear you, Jennifer. Right, we're going to let Jennifer find a stronger signal. Yep. So she's in transit, obviously. So I'm going to move now to Heather and Helen. We'll come back to Jennifer when she gets back online.
Hi, everyone. I'm Heather. I'm a GP in Dubbo, New South Wales. I've got a couple of motivations for joining in. One is that me and Helen and one other GP opened our practice about 12 months ago. So we are a new practice. So we're looking at, I suppose, our systems and how we can optimise our patient care, and we feel like we've got some pretty good systems, but we're in quite a good position to be reflecting on 12 months in on how we're doing things. The other reason, and I probably really resonate with what Wendy said, is engagement of patients, especially with other allied health professionals, because obviously as a GP, I feel like I don't have enough hours in the day, and there's a lot of very capable allied health who can come in and provide better care than I can in some areas. And there's a lot of resistance from patients, especially around seeing, say, dietitians or educators. Most people are happy to see, say, a podiatrist, but there seems to be a fair bit of resistance. So that's a real barrier. So what are some factors that we can do to encourage that? Because one of our focuses in our practice is to sort of have a lot of multidisciplinary approach. So we have a dietitian on board, and we're looking at other allied health to incorporate in the practice.
Great. How exciting is it to be able to build your own practice?
Exciting and very big job.
Yes.
But yes.
And if I could maybe summarise, I think what I've heard then from our colleagues is it's issues around patient engagement with services. And another way of saying that it's marketing our service or selling our service. You know, look, it's laying out our store of wares and saying to patients, you know, come on, you know, but buy what we're selling. How do we do that? How do we get patients engaged? And then there's something about coordination of care. So how does my bit coordinate in with the bits that other members of the multi-professional team are providing? And how do I do that in a way that is coordinated with everybody else? So we provide a holistic service to patients, and also in a way that doesn't duplicate, and maybe, you know, we're not maybe working at cross purposes. So trying to just make sure the whole thing knits together. I think I'm hearing those two themes, and so patient engagement and something around coordination of the whole service, and what's my part in this, something like along those lines.
Does that resonate with everyone? Yeah. Ideal then. We'll come on to test that out when we talk about your problems. So this is where we are in the programme, and next week we've got a workshop on delivering care that matters. So we look forward to seeing you at that workshop. So Therese, I'm just wanting to confirm that that workshop invite's gone out to all participants.
Yes, you would have received
Beautiful.
the invite from Katie.
Beautiful. Right on. So in the last session, as in the last coaching session, so we reflected on what matters to patients. So the conversation there was around actually outcomes do matter to patients, and I think that's reflected in the conversation you've just had there, as in we put in place the system to help people achieve better health outcomes. So we talk about patient-reported measures, so outcome measures and experience measures. So we talked about the challenges in delivering optimal care, and that's where we got this long list of issues and challenges that the system presents, right from the patient engagement right through to how do we deliver that connected, coordinated care. So I think Jag's just synthesised the breadth of the conversation we had in the last session. We also explored the context within which you operate and said, well, actually, from a quality improvement perspective, it's critically important that you understand the context. So what are the internal factors that you contend with when delivering care for people with diabetes, but also what internal factors support you in adopting that culture of excellence and driving improvement. So those internal factors and also the internal constraints. So you taking that strengths approach, addressing any issues or challenges that you might have. But then also thinking about the external environment. So what's happening around you. So think about the extended care team. And in the last session, some people were identifying the fact that there was maybe gaps in service provision within their sort of multidisciplinary team. But then the major issue was understanding what services were there and how to access them, and then how to coordinate them and connect with them. So that was that integration agenda, that team-based care agenda. So internal, external factors also included. There was a little bit of a conversation about patient registration in the last sessions, and how do you leverage that? And then a nod to the chronic disease management changes that will be implemented in when, Jag? When are those changes happening? $20. You're $40 in the red there, Jag.
Oh, is it back again?
Yes.
Oh, that's right. Oh, Angie, I don't know. Our admin team sorts that out. They've.
Yeah.
I'm just keeping well away from that. Yeah, whenever it is.
Yeah.
God.
But keep it on your radar. CDM, extra funding. So yeah. Yes. So yeah. And then we started thinking about your problem statement, and that's where we left it. As in, we provided a template for you to go away, reflect on your context, reflect on your data, reflect on what that data was telling you, what picture it was painting, and what are the problems you encounter and your patients encounter. What are those pain points? So what we want to do in this session is consider those problem statements. Think through how we use the problem statement, define our aim or our goal for quality improvement, and then think what the next steps are. Before we move on, any quick reflections or learnings about the last session? Any key insights you got from maybe shifting the lens you focus on? Any learnings from that activity?
I was impressed with the range of patient engagement survey material that was available. I hadn't realised that that kind of soft data could be quantified quite so well. We don't tend to use as much kind of patient satisfaction survey data as we could. So I think that's probably an area for us that we could actually start to implement. It was what was the website name that had a whole lot of the iCHOM website?
Yes.
That had a lot of interesting surveys. So that was something that I learned.
Yes. So the iCHOM website, so those iCHOM measures as such, those outcome measures, if you recall, were sort of evidence informed, and the rigorous process that international development group goes through to develop them is by working with consumers and clinicians and others within healthcare to define what matters to patients, and then pulling together the tools, the measures that are available to help sort of identify what matters to patients, so that you as clinicians and practice owners can then work out what measures you would want to implement within practice. So, and then also referenced within the last session was the work that New South Wales Health is doing in rolling out, is it LUMOS, Therese? Is LUMOS the outcome measures tool?
Yes.
Yeah. So New South Wales Health is at the vanguard of patient-reported measurement. So, and they're building a platform so that both primary healthcare and acute services can work together to measure outcomes of things that matter to patients. And again, on LUMOS, there may well be a suite of measures you can easily access to help you do that. So, yeah. And from a values-based healthcare perspective, I think it's really important that we start getting our heads around it, because this is the way the system's moving. So if you think about the 5 aims under value-based healthcare, the quintuple aim, better health outcomes, better consumer experience, equity is the new one, best value is the next. So the best value agenda arguably start thinking about how do we shift acute care into the community and primary healthcare, arguably, as would the equity agenda. So, and then the other component of value-based healthcare and the fifth element is around the staff experience. So, and that joy of work. So how do we get people working at their top of license? But more than that, how do we get people collaborating and working as a true team, as opposed to satellite people, individual services who provide ad hoc services on occasion of service basis, as opposed to part of the team with a focus on what matters to the patient. So, and how do you use tools such as shared care planning tools? So that the PHN is currently enabling in a few practices. How do you use the shared care planning tools to actually support not only shared care planning, but also engagement, collaboration, communication across all of the key healthcare professionals within that individual's patient's care delivery team. So there's lots going on, but yes, we will see an increasing emphasis on outcomes, be they health outcomes or be they experience outcomes. Therese?
And I was just going to say, if there's any of the practices on tonight that aren't on LUMOS or the shared care platform that Angie's referring to as Inca, and you want to get more information, please reach out and I can get the information through to you.
Because this is about what those two tools as such is about building the infrastructure to help primary healthcare and the system deliver better care to patients. So, yeah. Any other reflections on the last session? Teresa's going to pop into chat the reflection sheet that we used last time, so feel free to use that yourselves. We encourage you to do it. So that's the reflection sheet in terms of the what, so what, now what. So concepts. So what did I learn? What did I pick up? What are the insights I gained from this session? The so what being either then it's a bit of reflective practice, so maybe it's reviewing performance. CPD hours might be relevant here. So thinking about the so what does this mean then to me? Whatever position you've got, to my practice, to my patients, to my team, to the system. And then the now what being, well, actually, what am I going to do about it? What can we do about it? And that might simply be, I'm going to reach out to Teresa and the team. I'm going to get further information on Lumos or Inca shared care planning tool. So it doesn't need to be difficult. It's just a useful tool. And then also we've got, so Jennifer said she's got a problem because she hasn't got access to them. It may well be because you're on the phone, Jennifer. So we'll circulate them as well. So don't worry, you'll get access to them. And the things that actually we shared in the last session, so and that have been redistributed, so they're there. So radio, let's move on. So tonight's agenda.
Well, Ange, I just wanted to say just one thing. This is just based on experience from being involved in service improvement programs. Just to slap a health warning on some of what we've said so far, colleagues. So sometimes I think what I've experienced as as a colleague who's supporting as a coach is that when we start to look at all these resources, the IHI, the Lumos initiative looks amazing. It's great. And at the same time, sometimes some colleagues can feel almost overwhelmed by, my God, there's so much stuff. It's like I've barely got enough hours in the day to see the patients and carry with everything. So I think I just wanted to say, firstly, just to acknowledge that it may be how people feel. If you're not feeling that way, that's terrific. But if you are, just to acknowledge that. And secondly, just to say, please don't feel overwhelmed by this, because the point here is that the resources that are there to support you. They're not there to get in the way of you just having a go. At the end of the day, it's just about having a go and doing small steps at a time. And of course, we'll support you through that in the coaching program. And the other thing I wanted to say was there are actually plenty of ways of skinning a cat. So, the IHI, there's a whole literature around how health services do this. I've got a background teaching management. So, for example, looking at patient engagement, well, businesses have to do this. They just call it something else. They call it marketing. They call it client engagement. They call it co-design. So there's lots of ideas and literature that we'll look at that may just generate some ideas that then you can decide how you apply. So I think I just wanted to flag that so that no one is feeling a bit, oh my God, there's so much. There is a lot, and that's okay. We will help and support you to look at how you might apply that.
Radio then. So our aim, Jag and my aim tonight, is to get you to the point of defining your aim for quality improvement. And Jag was very helpful in coming in there, as in is choose one thing, choose a small thing, make it smaller, because as he said, quality improvement's about small scale incremental change. So that's our aim for tonight. I'm just wondering, what's your aim for tonight? Have you got a specific goal? Something that you want to achieve tonight?
I think what I want to achieve is just to become a little bit more familiar with how you go about developing that goal to make it practical so that you can actually then work on it and apply it to practice. That's what I'm hoping.
Great. Anyone else got anything to add to Rebecca's feedback? Ready up. Feel free, take yourselves off mute anytime.
I don't know whether this is the right thing or the right time. Sorry, I came in a little bit late at the beginning, so I'm sort of a little catching up. But I guess one thing I'm probably trying to get my head around as an allied health clinician is just noticing how overworked the GPs are out in the country and how understaffed we are with GPs. Not understaffed, but under-resourced with GPs. And then that also that the fact that the patients don't want to engage with allied health, and there is a great allied health workforce. And so, you know, we could take a lot of that pressure off from the GPs to work, you know, really coordinate the care really, really well. Yet there is that lack of understanding sometimes by some of the GPs as to what the allied health do, and to be able to explain what the allied health can do. But then it is generally from the patients wanting to engage with the allied health. So, sorry, yeah, that's right. The patients don't want to engage with the allied health because what is that? That's probably the big question, is why don't they want to engage? Yet there is this constant complaint of they can't get into their GP. So actually the utilisation of the allied health would probably ease that burden, because getting GPs is not going to be something that we're going to fix anytime soon. And so this isn't a problem just to diabetes care, it's to all chronic disease management. So getting back to your very, very first question, that's probably what I've been interested in coming into this work, because I don't actually do much diabetes. I do a lot of other chronic disease things. So just to see how this works, bigger picture. So that's probably my problem that I would define. That's a big problem.
Heather, if it's right to ask her. So Heather, if we're playing here now, but if we allow you just one sentence, right, which is a question, what would your question be?
Oh, I'm Helen. Sorry, that's Heather.
Oh, Helen.
Yeah, that's okay.
Sorry, Helen. Yeah.
What would be my question? Oh.
You could start with, is it a why, a what, a where? Which question word would you use?
Well, I'm not sure whether it's how to. I mean, it's always coming back to this engagement. But if you know, why do patients not want to engage more with allied health? Is possibly the question.
Oh, for their diabetes care. Wonderful. I think that sounds good. Ange, so why do patients not engage with allied health for their diabetes care? Yeah. I'd like it. Ange, any thoughts?
So that's your question. How do you, right, can we take a step back, and you've outlined the problem. So to outline the problem, you have to understand the problem to define your question. So I think we're moving into like improvement activities and maybe thinking about what we need to do. So we're going to unpick the problem. So, but what I think we need to do, maybe Jag, is for everyone to share their problems, and then we test the robustness of that problem.
Sounds good.
Are you okay with that?
Yeah, that sounds good.
So,
and Helen, Heather, just hang on to that, because that
yes,
it's good listening to you, and just maybe just write that down, and that's that's great.
Yes.
Because it does sort of, there's some truth there, isn't it? That encapsulates a lot of what you said. And I guess for everybody else, it's this bit's always quite tricky because there's a lot to be said to give context, and trying to squeeze it down to just one phrase is hard, but that's really good. So thank you for that. That starts us off. And so, and was the idea then for everybody to just have
please.
Just have a go. Yeah.
Yeah.
Great.
So actually, can you just drop your problem statements into the chat box? But I want to also extend what Jack's just said in terms of quality improvement. And then in the first workshop session, we talked about data-driven improvement. Well, the data you need is driven by the question you want to ask of the system you operate within. So why do patients not engage with allied health for diabetes care? A great question. Got to think about what data you need to answer that question. So yes. Yeah. So problems, and then we're going to together test whether or not the problem statements are robust. You may have similar problems. You might want to work together to sort of refine your problem, or you may not, because your problem definition is going to be explicitly contextualized within your practice.
So who else is going to have a go?
Like I started typing. I'm a terrible typist. I don't know whether this is part of what you're asking, but I think a lot of the allied health stuff is, so I'm in a diabetes educator role. Some people either don't know you're there. So at one stage I started writing newspaper articles in our local paper, talking about, the differences of diabetes, type 1, type 2, GDM, portion plate, different topics, every few weeks or so. At one stage I did a Libre group session thing. There was 3 of the people there didn't even know that I was in that position, that there was a diabetes educator. So it's trying to get people to know who's here. But it's also, there's not enough of us either. So there's always a wait list. For our dietitian, we've got the one dietitian for the hospital. So she does 4 days a week here and 1 day over at Grenfell. Like, she's got this massive wait list. So if I've got a GDM or a type 1 person who's just been diagnosed or whatever, she fits them in within a week or so, God love her. But she has got this massive, massive wait list, which would do my head in. There would always just feel like you've got 1,000 jobs sitting on your shoulders that you can't get to. So I think the support for allied health and diabetes educators as well, it's trying to, you've got families, you've got jobs, you're trying to cook dinner. Mine will just eat leftovers tonight because I can't walk the dog, do this and get dinner. It's promoting it whenever I talk, like after someone's had a session with me and they go, oh, like, that was actually really nice. That was really helpful. I thought you were going to get angry with me. That's not my job to get, but that's what we used to be. No, you can't eat chocolate. You can't eat this. Or, if someone tells me that, I'm just going to bury my head in the cupboard and eat the whole block. So I try and put my personal stuff into how I speak to people. The dietitians, like you say, oh, would you like to go and see the dietitian? Oh, no, I saw a dietitian once and they were horrible and blah, blah. And I said, look, we've all learned a lot. And I said, we were the same. We got told what we had to say to people. I said, the dietitian is just going to just check out what you're having nutritionally through the day. It's a healthy and varied diet. Means you can have cake if it's someone's birthday, blah, blah, blah. But they're just going to make sure you're getting all the energy needs you can so that you can go for a walk with your friend or do all that. We need more promotion, more staff on the ground, more positions. I'm currently trying to get, I'm just waiting for recruitment, which I think will take forever, to see if I can get a 1 day a week position at the hospital to just help educate some of the staff and the new grads on diabetes stuff, see patients on the ward. My aim is to get a diabetes clinic going there. There's 2 educators over at the base who would absolutely be smashed as well. Like, why on earth you would stay in that role when you're getting flogged every day? Like, they must be exhausted. So the government needs to support those supporting pre-diabetes, all that sort of stuff. So I'll try not to rant too much this week. Sorry.
That's good. If it's all right, Ange, and that was Jennifer that's talking. Is that right? Have I got that right?
Yes.
Yeah. Jennifer, do you want to have a stab at also the question? So the rule is you're allowed a phrase, which is a question. And what do you want? Do you want to start with a how, a what, a why? What would you like to ask?
One phrase, you don't know me very well, but anyway.
It's hard, isn't it?
Oh God, you should see my emails and the letter I sent to the government recently. It was 7 pages.
So do you ask a how? Do you want to ask a why? Do you want to ask a which word do you want to start with?
How are we as allied health, diabetes educators, etc., to continue our role as well as our, work-life balance, which I have none, without imploding? Like, we're trying to give as much as we can to the people we see, and we're not, like, we've got the PHN who's stepping in to help us, which is just unreal. Like, I'm so excited with that, because I think you just, especially in rural areas, you feel alone. How do we not feel alone and get burnt out? How do we get soldiers?
Oh, that's interesting. That's interesting. How do we not work alone and not get burnt out as diabetes educators, you said?
Well, diabetes educators and allied health, like, same with our dietitian at the hospital. Like, there should be at least 2. Like, one is just insane, and it's really hard then when she's going to another town on 1 day a week as well. But to be able to do your job, and then you've got to try and do all this other data stuff, and you can't do clinical and all of that in the hours and the staffing that we have. Like, the government needs to step up in that. And I'm trying really hard not to swear.
That sounds good. And interrupt me then if I'm going off topic. But is it all right if I just ask Jennifer a couple of questions?
Yes, and then Wendy's got her hand up.
And so, Jennifer, my question would be, okay, so because there'll be some things that, they talk about spheres of control, some things that are out of our control, aren't there? For example, the funding that's coming from, state government, from the centre, all of that's a political thing, isn't it? Which could be its own quality thing, and probably is something that we don't have direct power over. But what we do have power over is, I guess it's about, I'm hearing you in thinking about maximizing your time. So do you find that you're ever duplicating tasks? You're not quite sure what you're doing, what the other people are doing, and how could you maximize your time? Is it something around that or not?
I'm not really duplicating tasks because I'm it. So
Okay.
I'm the only educator. So I think it's like, where you're saying we don't have the power. Like, why the hell don't we have the power? The government should listen to us. We're working in this area with people. We are seeing what they're going through. I've got people that cut their tablets in half because they can't afford to get their next script or whatever. And people say, but then once they get to the whatever the level is, and then it'll be free. They don't have enough money to do that. They're scrimping with every little bit. So all these diabetes services, and like venting last time about the EPC visits, you've got 5 for the year. For someone with chronic health, that's not enough. I've got one fellow that I saw yesterday who, God love him, he tried to cut his nails before he came and saw me because I said that this time I'd do a foot check, and I always say, joke and say, just make sure you get all that toe jam out before you come and see me. And so he cut his nails. He's got arthritis. He cut his toe. Like,
so do you, in fact, is your quality improvement about advocating for more resources? So in which case is your question, how do I exert political power and influence to advocate for increased resources for allied health services diabetes? Is that what you want to do?
Yeah, so I've written a letter to Steph Cook, our local member, and to the Minister for Health, saying that we need a full-time diabetes educator. I don't want to do it. I don't want to do full-time, and I've already got a job, but I'll do an extra day there. But that needs to be a position at Cara Hospital. So I've written to them, and that's my bit to try and get that discussion. Last time I used to do it when I was a kid too. Mum would always just tell me to go and write to the government. So we, don't have a community sharps thing. So I sent off a letter. I spoke to the hospital. I spoke to whoever I could listen to counsel and stuff. So now we're just about, it's nearly taken 12 months, thank goodness. But anyway, we're now about to set up 2 community sharps bins. So, because, you know, there's sharps in the recycling, in the library, you know, return book thing, there's sharps shoved in there. So it's to try and bring all these things where you talk to someone.
So I guess it's so interrupted, and it's really interesting. I can hear your passion. I guess what I'm wondering is, because our focus today is for us to get to a problem statement, and obviously, Jennifer, it's your energy is fantastic. You know, lots of different things you want to do, which is amazing, and to be really infuriating. And will keep us on track here. It's about just focusing on one thing. You're only allowed to pick one. I know everything needs to be done, but in the sense of clarity, it's just about keeping that focus. So do you want your focus to be on the politics, which it could be around, you know, how do I advocate for my, because there's a literature around it, you know, what would successful quality advocacy mean, you know, because that could be something you could into, or it could be, you know, something else. You're going to have to pick a question, or we're going to force you to pick a question, simply because that's the process. Otherwise, you'd end up being in 70 billion different directions all at the same time. Does that sound fair?
It's probably.
And we will come back. So Rebecca, we will come back to actually give you a tool to work out what's in your sphere of influence, and what small step you can change, you can take, and one area of improvement you can focus on, because incrementally, we need to take small steps. We can't change the world, but I love your advocacy, I love your passion, and just keep lobbying. So, but then also, just as a sidebar, you might want to connect in with the PHN. So talk to your PHN practice development officers to see what may or may not be happening within your region as well. I'm just thinking about the commission services, Therese. And we
interact with Jen.
Yeah, great.
Regularly, so yeah.
Right. Wendy's had her hand up for a long time. And then, sorry, is it Wendy? Yes. Yeah. And then I'm going to come back to Rebecca. Wendy?
I'm unsure if I have how to do a problem statement correctly, but what comes to mind is something like, how do allied health staff at the service where I work market ourselves or market our service to engage or increase engagement of people with diabetes? I've tried looking at the sheet, but I'm not sure how to write it. And we have a bit of the opposite problem to what Jennifer was talking about. We struggle to get people to come to allied health, which then puts us at risk of losing our positions, our funding. They're there, but they don't come. So sorry, I've just added that, but I'm not sure how to write the problem statement or.
So you could write it as a question. Our problem is, how do we raise awareness of the critical role of allied health in relation to evidence-based diabetes care, and get them to understand and come to us? And
Okay, thank you.
So,
and I'm wondering just about, how do we attract people to our service?
Yes.
That's it. How do we attract people in?
Yeah, keep it succinct.
It's, you know, I'm being mischievous. How do we lure people in? You know,
well, about that. Yes, I've got to lure people in well and truly.
Play with it, you know. Play with it. You can turn up the temperature. I mean, rather than being dry, it can be, you know, how do we, you know, maybe play with the words. Attract, I think, is a nice word, isn't it? How do we attract people into our service?
So Rebecca's got a different problem. Rebecca, explain to me what your role is. Explicitly, sorry, I didn't pick up that. I know you work for the LHD, but I don't understand what you do.
That's okay. I work for the LHD. My role is an integrated care coordinator. I'm a registered nurse. At the moment, all patients admitted to hospital run through an algorithm in the patient flow portal. Patients that are flagged as being at risk of rehospitalisation within 14 months are referred to our program. We have an intake team that screens them. Anyone they consider may have factors that could be managed better in terms of community support or chronic health problems that need improvements in management are then referred to a coordinator. We go in and do a comprehensive assessment, identify where there may be gaps in management. We provide health coaching, care coordination, care navigation, linking people into services. So at times it can be very overwhelming, and the majority of people that we're seeing have quite a few comorbidities in terms of physical health, but the biggest factors are those psychosocial factors that Jennifer was talking about. So it can be overwhelming for the patient, but it's also overwhelming for me because my role's a very generalist role. I'm working across sectors, and there's not always good engagement across sectors either, because everybody's very busy within their own world doing their own thing. And the patients that I'm working with, because of all the psychosocial factors, often have multiple barriers to engagement. So it's very hard work trying to get them to engage and to know, well, how much information do I need to give them? What information do I need to give them? Do I assume that other people like their GP are doing all the work, or do I write a report back to the GP and say this person doesn't know what their HbA1c is, they're obese, they're not keen to engage with a dietitian I recommend? So it's just trying to work out, I guess, a simple and clear pathway that, or even a tool that I can use with a patient so that I'm not overwhelming them, but at the same time I'm giving them reasonable direction in terms of what may help them manage their diabetes better.
So I'm going to be provocative here.
Yep.
How does that role duplicate with the role of the GP? So when you mentioned they're undertaking a comprehensive assessment, when you mentioned they're developing a care plan, identifying gaps in service, so how does that sit alongside the GP in the practice who get paid for that?
That's a very good question, and that's part of what I'm trying to work out as well. So within our program, the patient is at the centre of what we're doing, but so is the GP. So that we do the report, we feed back to the GP, then we try and work with the GP. What makes it very difficult, though, is not all GPs have the time to do that. Not all GPs have practice nurses either that can pick up some of the slack and help with doing that. So it's very ad hoc, hit and miss, and no real standardized process for it. So
your
a lot
context is very dynamic. The patient's needs change. They're highly complex patients, but the context within which you operate on an individual patient level changes. So it's dependent on the general practice context. So some people will see you as an enabler.
Yes.
Other people might see you as a challenge. Because you're potentially duplicating. So is your challenge understanding how each practice operates to work out how you can maximize the value of your time and resource and spend that with the patients with complex needs where there's maybe a deficit in the primary healthcare system?
I think so. And I think what it keeps coming back to is we haven't got to a point yet where there's some really good communication happening between services. So, and it may be a bit controversial, but the Ministry of Health has developed a program. They've put it into health, and I don't know why that is, but I would see our position sitting better within primary practice or with the primary health network where we could work with various practices, because we haven't got systems that communicate. I don't know what the GPs are doing. They don't know what I'm doing. And we haven't got a platform that allows us to share a care plan. So you're talking about, for example, Lumos
Inca.
and Inca, which we don't have access to when we're working in health.
Yeah, Rebecca, LHD have access to Inca.
So how would we go about getting on board? Or
Can
do
you
we
reach
need...
out to me?
Yeah.
And I can get this sorted for you?
I will.
Yep.
Yeah.
But recognising the fact that Inca is a tool, you need the primary health care, the allied health and the LHD
And the
working
GP,
together to
Yeah.
utilise it. So,
Yeah.
and we're rolling out.
Yeah.
But
And
sorry,
there's
I was smiling, Rebecca, because we had a similar service in the ACT. It's still there, actually. And 10 years ago, we had the conversation, why is that care coordination service sitting in the equivalent of the LHD system, when actually care coordination arguably is about trying to coordinate care to keep people well and out of hospital. So yeah, pick them up early, pick patients up early, identify the high risk, coordinate their care, increase their level of education and activation. Yeah,
absolutely. And we need an MDT. So
Yeah.
it takes more than just one position to keep people out of hospital. It's multiple positions.
So what's within your
that's the
sphere of
challenge.
control?
That's what I'm trying to work out. And all I can what I've been looking at or thinking is perhaps looking at the diabetes cycle of care that's used in primary practice, and then using that as a template with the patient to say, are you familiar with? And sometimes I'll say, oh yeah, the doctor's doing this, this and this. And usually they're fine and I just let that go. But it's a small group of patients that are not engaging with their GPs, and they're also not engaging with allied health, with the diabetes educators, dietitians, and so on. They're probably the group that I try and just chip away at and give small messages and promote getting into these other services and back to their GP.
Yeah.
But it's very hard, especially when it's not my area of expertise. I don't have that high level of skill. So it's trying. I have actually picked patients up and taken them in to see diabetes educators and taken them to the dietitian and recommended physiotherapy and exercise physiology and all of those things. But I get worried then when I'm the person doing all the transport and travel and linking in. Once I step away, then it falls over. It's trying to work out how I can make that sustainable.
Yeah. Right, Jack, and then we're going to go to Heather and Helen.
So just to ask again, and so sorry, it just on my screen, I can hear people, but I can't see who's talking.
That was Rebecca.
Rebecca, just to give you the same, supportive challenge. So what would your statement be? What would your question be if you're going to have a stab at it?
I think, how can I contribute to the better management of diabetes for patients with multiple psychosocial barriers?
Oh, like it. Yeah. And then the slide then we could almost work through, isn't it? For whom is it a problem? Why is it a problem? You've touched on as you're explaining the background, and yeah, that makes sense. That's great. Thank you. Thanks very much.
All right.
Thank you. Heather, Helen?
Yeah, it was just me, Helen, probably more wanting to make an observation that, I mean, it sort of seems that there's some allied health, Wendy, you know, being a dietitian like me, possibly in private practice, I'm not sure, I wasn't here at the beginning. And I mean, I'm a practice owner, I'm in private practice, I am, you know, people won't see me for diabetes, they'll see me for pretty much every other chronic disease condition. And they'll pay for that. And yes, my private rates are pretty high. But if I was to see a client with, you know, the EPC rebates for dietitians are, the schedule fee is $65 for 20 minutes and the rebate's $58. But I cannot do anything in 20 minutes. So I see people for an hour and my fees are pretty much 20 minutes times 3. So people can't afford that. And so the hospital system gets overrun with people who cannot afford private dietitians. As a practice owner, if we are going to make our practice sustainable, then we have to pay fees, you know, charge fees that we can sustain a practice with. So the people that will come to me are the people that can pay for an hour's consultation. And that's possibly one of the biggest factors to engagement. And it seems that that's what we're sort of highlighting. We've got the people in the hospital system who are overrun with people who just can't afford the private fees to see allied health. And then we in private practice are stuck with the struggle of how do we run a practice. I am not going to bulk bill. I'm sorry. I would prefer to be at home with my family and my dog than to pay to work for 20 minutes and not do a good job and then have to spend half an hour writing a letter to a GP because it's not feasible. So I think that's one of the really, really big challenges. So it's not just about the government funding the hospitals more, it's actually the what happens in primary health care as well. Like to keep the patients out of the hospital system or away from the dietitians in the hospital system, because they can't do that there either. So I think we've got two lots of allied health, one in the public hospital system and then in private practice, because the ones in private practice aren't getting the engagement for lots of reasons. So I just wanted to identify, that's what I'm sort of observing.
You know, and Helen, I think it's more complex than that. I think there's 3 cohorts of allied health providers. So there's the public health system, there's the private health system, but then also there's the commissioned services that the PHN's commissioned to fill gaps in allied health in some areas across the region.
And then you've also got, like Wendy's just put, she's from an AMS.
Yes.
Funded differently again.
Yes. Yeah. So, and that's the challenge, I think, even understanding what's available. So Rebecca, diabetes cycle of care, we talk about evidence-based care, point of reference for diabetes care is the cycle of care. So obviously I think you're quite right in that respect, but the issue is how do we make sure that people are getting access to services? How do we know what services are available, and how do we understand the personal motivations and the personal circumstances and challenges of people? Because unless we understand A, whether or not it matters to the patient, B, whether or not they can access the services, are they available, and C, whether or not they can afford the services, you can think through, well, actually, is that they potentially a bit barriers to access. I'm just mindful of time, everyone. So I just want to come to this checklist. So I think you've talked about the issues and the challenges. You've talked about the questions you might want to ask, and you can translate that into a problem statement. But the reason we put this sort of list up of questions you can ask to test your problem is because actually what we want you to be able to do is finesse your problem down to something that's tangible and manageable. So, for example, you've got a better understanding of the breadth of the problem, and you've got a better understanding of where you want to focus your QI activity. So taking, for example, that scenario that patients don't engage with us. Well, we know that some patients do, we know that some patients don't. So therefore, for whom is it a problem? Is it a specific cohort of people? Can we define that cohort of people? And therefore, can we focus on that specific cohort of people? Because if the rest are engaging, not a problem. Is it a specific cohort of people? So why is it a problem? So if we look at the quality improvement circle there, the blue and the purple one, so patient involvement is something that wraps around the QI approach. So has anyone thought to ask patients? You've all got perceptions which are valid, but has anyone actually gone, and I think it was Heather who mentioned this before, in terms of those measures you could use, those tools you can use to actually engage with patients. Can you do a little bit of delving to ask them, why is it a problem? So what are we missing here? Why does it matter? So you can all clearly define why it matters, but can you ask a patient, why does it matter? So yeah, when is it a problem? Is it a cyclical problem? Is it not a cyclical problem? So is it a social problem? So boom and bust. So it might not be a problem when we've got high employment rates and people can afford to access care, but what's our current context and so forth? So when is it a problem? And what does that data show us? You've got data on activity in terms of access. You can profile the patients who can access services. You can work with GPs to profile the patients who aren't accessing services, or you work with general practice, or you can work with communities to help them. So the reason we put this up is the more granular you can get in your thinking in terms of what is the problem, who's the problem for, how big a problem is it, when is it a problem, and so forth, the more specific you can then translate that into a name statement. But another useful tool.
Ange, is it possible just to say something just about patient engagement? Just a couple of ideas, colleagues. So, it's the idea of colleagues. For example, the question of how do I make my service more attractive? You can ask patients at the end of a consult and say, look, I'm just wanting to figure out what would make this more attractive for you or for other people that come into the service. Just I'd like you to tell me, and then you can capture what they say. And what's quite interesting now, so everyone's heard of ChatGPT at the moment, haven't they? So what's interesting is you can capture what the patient said, and you can feed it in to something like ChatGPT, and it will just produce a summary of what patients are telling you. So I think this is pretty revolutionary, because what it means is you just have to ask the one same question to every patient you see. And what happens over time is you'll start to build up a picture of, these seem to be the things that are important for our patients. It's the sort of thing that if you don't ask, you don't know. But if you just ask the question, you can start to build up a rich picture. So maybe just to start to think about things like that. I mean, other things can be done as well, which is, you could run an evening meeting to see if we, just put on some tea and biscuits for the punters and see if they'll come along, and run a focus group. You could do that. It's just trying to be creative around how you get people to tell you what it is that they would like. And then the key aspects are obviously, what they say, but also the words they use as well, trying to capture. So we may get into that in more detail in some of our subsequent sessions, but just ways of being able to engage and ask the right questions, open-ended questions that get people talking. It'd be interesting to find out what you've put into practice and how you can use some of those practical skills.
Thanks, Jack. Now, a useful tool to help you No, Jennifer's problem. Jennifer, I'm going to bring you in again. So your advocacy, that's vast. And some of it may be in your sphere of influence, some of it may not be in your sphere of influence and control. And when we come from a QI perspective, it's that influence and control. So we need to understand what's the root cause. Oh, we've got 2 Jennifers online. So which Jennifer? Have we got an extra Jennifer? Or is it the same Jennifer twice?
And we've got Jennifer Richmond, who is from Cowra,
Right.
the diabetes educator, and we've also got Dr. Jennifer on as well.
Oh, right. My apologies, ladies. Sorry. Yes. Righto. Who raised that issue in terms of that broader advocacy and government needs to do this, that, and the other? Which Jennifer was that?
Richmond.
Right. In Cowra. In the car. Yeah.
The one
Right.
verbal diarrhea.
We wouldn't say that.
No, passion.
All
Yeah, it's
precious
passion.
level.
Well, then that's a huge problem, isn't it? So what we can use is we can use root cause analysis to work out what sits behind that. So things like using the Ishikawa diagram, root cause analysis can help you hone in on sort of your problem. So Jennifer mentioned the fact that we haven't got enough skilled workforce in, so let's sit under the people domain. Environment, we're rural and remote, and therefore whatever. So methods and equipment. So equipment, we haven't got an integrated care system or tool that we can use to coordinate care. Make sure that we don't duplicate, make sure that we identify care gaps. Methods, we haven't fully integrated a team-based care approach, so that's Wendy's, Rebecca's problem. So materials and resources, we haven't got these. So that's a huge problem, and this tool might help you drill down, Jennifer and Cowra, where you want to focus your efforts. So, but it works with defining what your problem is, assessing your problem, and you can add other dimensions if you choose, asking the 5 whys. So why haven't we got enough people? And so forth. And some of it you'll work out is not in your sphere of influence, which is where the advocacy bit comes in. And I'm all for picking up an advocacy umbrella and making sure the people who need to know. But then also it helps you identify from a QI perspective where your sphere of control and direct influence is, so you can work towards developing a better service and care experience for your consumers. So any reflections on that tool?
I think I've just blanked.
Yes, I think we're just tired, aren't we, at this point in time? It's a useful tool to work out the different dimensions of your problem, what's leading to the problem. So if your problem sits on the right, what are the key factors that are contributing to the problem?
I'd need to see the tool like in front of my face, like written down, like, because I can't look at any of the things, so I can't.
Yeah, sorry, Jennifer, you're on the phone, aren't you?
Yeah. Like, I don't know. I try and sit and have a bit of a look, and there are so many facets, you know, people either can't afford systems. We don't have a private diabetes educator. We don't have, you know, people, we're trying to make it viable for our practice. So we're starting to do the EPC forms, but then if they have 5 podiatry visits, they wouldn't be able to afford it. So we just build the nurse number. So we're trying all the different things. And like the hospital, I occasionally see people up there until I get a job. But, you know, how viable is that? And that's my time and stuff going, that I'm seeing people up at the hospital and then I'm not getting paid because it's not a general practice problem. I don't have a job at the hospital. So, and then legally, how am I standing? Like, I've got, you know, professional indemnity and things like that. But, you know, it puts us in a tricky position and our job's already hard enough. So I'm at the point where I'm so tired I can't problem solve anymore. I'm doing what I can to try and improve things for our
Survive.
and like I have, staff at the hospital, of parents calling me from another practice, oh, look, blah, blah, blah. And educators at Orange are really flat out, and I, haven't got any response from emails. They've just got a kid who's less than 6 months being diagnosed with type 1 diabetes. So, I meet them up at the coffee shop and have a bit of a chat and do some sort of advocacy. But that's not a good system. We can't exist on that, and that's not good enough for the people we see.
Yep.
It's all right. I'll write an apology email to Therese tomorrow for my blurbs again.
No.
Is
Okay.
I hope this is helpful. This is meant to be helpful. I mean, the colleagues will judge if it is or isn't. Look, we completely empathise with so many challenges in the system, so many moving parts, so much going on, and that's true of diabetes care. It's true of all aspects of the health. So as I work in aged care, it's the same thing in aged care, and that it's acknowledged, it's true. And then there's something about taking a deep breath and trying to then just squeeze out, okay, what's the one bite-sized thing that I want to work on in terms of service improvement? And it's hard because there's so many different things that we all want to do. It's just that quite clearly it's impossible to do the whole lot, and so it's got to just
And you'll burn out.
You'll burn out, and
Yeah.
so I think today is about listening, acknowledging, of course, and then I think Ange and I, as your coaches, saying a bit like my swim coach does. I'd love to be perfect at swimming, and I'm not bad. But he just gets me to work on one little aspect every time. Right, let's just get you just stretching a bit further. He doesn't make me do the whole thing, because I would just collapse. All right, I just do one small thing each time, and then we get better. So that's the challenge, I think, colleagues. Is that fair for me to say, that acknowledging everything? You want to be better swimmers. You want to get everything perfect. Of course you do. It's just work on one thing. It's your kick rate. It's trying to get your hand in the water better. It's one small incremental change. And what is that? And you've got to be able to put it in one sentence.
Yes.
Yeah. I want better availability to people living with diabetes for, any of their education and stuff. That's what I want. So it's all the other bits. I find these sorts of things, these coaching sessions and stuff, I'm never good on committees and all that sort of stuff. It does my head in. And I think I feel like I'm just a mushroom in the back office. I do what I know about. There's so much out there that it's just mind-blowing, and I find these things quite challenging and overwhelming in themselves.
So
because
Rebecca, who is your practice development officer, link person in the PHN out at Cowra? Who would that be, Therese?
Beck is the initial, and I also give Beck a hand with Cowra as well when required.
Yeah, so I think there's maybe a conversation to be had to help you understand.
We've been discussing with Therese and Beck. Beck's been out a couple of times.
Yeah, but I think you're a huge advocate, and I think the whole region could do with maybe hearing a bit more, but it's maybe around how you do that. So there's something about advocacy, and there's something about influence, and there's different techniques you can use to influence that might be more successful than going down the pure hard advocacy road. So so I think there's something. So, and if you see that like leaders and influencers, they take the influence side rather than the direct hard-nosed advocacy side, and they play the long game. But I do really, really support your passion. And just to give you background, I used to be chief exec of a consumer health organisation, and my role was all around advocating for consumers, just the way you are. So if you're ever thinking about another career move, Yeah, so and Jennifer's just popped in a message there to say that that worked well at their practice. So running group sessions, yep. So right, we'll come on to that. So sorry, very good segue. So 7:20, we've got 10 minutes left.
Yep.
So these template here, we've shared it with you. Jennifer and Cara, you have access to it after the session. We'll circulate it again. But this is basically model for improvement, 1 page. Top, your title. So what's the quality improvement initiative you're going to work on? What's the problem? 1 or 2 sentences you want to work on. What's your aim? So the one sitting to the right of that top middle is what do you want to achieve? What's your aim? And as Jag has said repeatedly across this, let's keep the aim small. We don't want any big, hairy, audacious goals because basically we'll set ourselves up for success. We'll set ourselves up for failure. So keep it small, keep it focused, and then sitting alongside that, what do we want to achieve? Is thinking through what are the measures. So how do we know if that this change or changes we implement have led to improvement? What measures would we use? And then think through, we'll be thinking through what change opportunities, and we've already seen a list of change opportunities or potential actions you can take in relation to promoting the role of allied health, but promoting that concept of team-based care while better addressing consumer needs coming in here. So Jennifer's added in there. So yes. So where we're at now is understanding your problem. Challenge yourself to make sure that your problem statement is clear and succinct. Because if you can't articulate your problem clearly and succinctly, you ain't going to have people working with you. They just won't get it. So, and then translating that into an end statement. So we had 2 major challenges right at the beginning, Jag. You mentioned the fact that one is the patient engagement. Yeah. And then the other one is the coordination and connected care, that team-based care.
Yeah.
So our aims need to be specific, measurable, achievable, relevant, time-bound. Sometimes things are a little iterative. So you might go through the loop of testing your problem, looking at the root causes, finessing your aim, thinking about your change opportunities, again finessing your aim, drilling it down, thinking about your measures. Well, actually, when it comes to an aim statement, we want to know it's achievable. So are the objectives measurable? Yes or no? Well, actually, if you think about model for improvement, that middle one. So yeah, what are our measures? But also what's our highest level measure of success that we will build in our aim statement? So I'm going to throw this challenge to Jag in the interests of time. So taking that patient engagement issue or challenge, and you had some very succinct words in terms of, so I think it was, sorry, I've got my notes here and I'm sitting in the dark now. So how do we make people more aware of the services we provide? So how do you translate that into a person-driven aim statement that is smart?
Okay. So let's do it collectively specific. So what is it we're trying to achieve? So I might pick a quantitative measure for trying to do this. So for example, supposing it's the numbers of patients booking in for diabetes review appointments, I might want to see an uptake in, I might decide that that's a good measure. I might want to pick something like the number of patients who are recalled for diabetes care, the percentage of those patients who actually pitch up for their recall appointments. So to pick something specific that is then measurable. So this is where you'd need to reflect on, is this a good measure that we could use? I'll then look at whether that's achievable. And, you know, for example, things like recall rates, I think, yeah, that's reasonable. It's relevant because it's something that translates directly into a measure of quality of care. And then I'll make it time bound, because I'll give myself then a realistic time period over which I want to improve it. So supposing at the moment we send out recall messages for diabetes care, and I don't know, supposing only 50% of those patients actually pitch up for appointments, and I want to get this goal up to 80%. And then I'll have a team-based discussion, you know, multi-professional team-based discussion, which must include our admin team as well as the clinicians. And then we'll collectively decide what seems reasonable here. Let's maybe do this over 6 months. That might be reasonable. And the thing I think about this is, rather than being an individual sitting in a darkened office somewhere inventing this, I would suggest have this discussion with your team, with your teams. And in fact, even better, if you can get some patient engagement, that's even better. Get people involved so this becomes something that collectively you can own and then you can put into practice. So that would be the way that I'd approach it, Ange.
Yeah, then. So that was a general practice specific aid. Was that correct, Jack?
Yes, yep, that would be a GP.
Yeah.
Around recalls for diabetes, but I guess that probably applies for, I'm sure all of our colleagues from Allied Health as well will have recall systems set up. Probably, is that right? Diabetes educators, you probably work on that. Or I guess it might be the number of referrals you get, what percentage of patients actually then pitch up to appointments.
Yeah. So, but if the problem is the fact that for example, what we're thinking about is a GP might develop a care plan with the patient, a GP might put in place referral to Allied Health, but the patients don't then translate into Allied Health engagement.
Yeah.
I think that's the challenge I picked up from our Allied Health professionals here, diabetic educators and dietitians predominantly. The last session we heard that people are quite happy to engage with the podiatrist, but not the diabetes educator or the dietitian. So the aim, how would you define an aim in relation to that transition or that engagement or that marketing of the role or the awareness of the importance of engaging with those types of allied health within the cycle of care? How would you define that marketing type of aim, that awareness raising type of aim?
So then I would go back to my allied health professional colleagues, my diabetes educators, and say, right, what would good look like? So you were stating that there's a problem at the moment,
yes.
But what would a measure of success be? Would it be, you know, a full case list? And at the moment, I'm not. You know, I'm twiddling my thumbs for 50% of the week, you know, because people aren't good. So what would it be? What would you want to see in terms of your lived experience and then data on the ground? What would that be actually, diabetes educator colleagues? What would it be? So you're saying at the moment there's a problem with engagement. But supposing there wasn't a problem, what would the world look like? What would you be able to measure that would demonstrate that people were engaged?
Yeah. Does that make sense to everyone? Are you following that?
Yeah. And we'll probably just leave it as an open question just because of time. But, you know, you can imagine a perfect world where, hey, look, we're just...
Yeah.
All jets are fired up, and you know everybody who needs a diabetes educator, they're getting in to see us, and I'm full, and I can tell that it's engaged. There's got to be a way of measuring it that tells you there's a problem now, and that would tell you that it's a-okay if you were getting 100% success rate. What would it be? You know what the measure is, and that's something that you can then talk about in your team.
Yeah. So radio, that mindful of time, we've got 1 minute. just remind you, you've got your reflection sheets, so please use them to do that reflective learning. So we've got a workshop next week about delivering care that matters, and potentially it's going to pick up on some of those issues in terms of team-based care, the coordination of that team-based care. So how do we make sure we deliver the care that matters to the people that we serve? And that will be delivered by PHN. So you might want to bring your aim statements along to that workshop session with PHN. And then again, we go into, so we carry on. So coaching 3, we pick up on the aim, then think about model for improvement. What are the key measures you'll use? What are your change opportunities? Then we'll want you to develop a change activity, so a PDSA. So what are you going to do? How are you going to measure it? How are you going to review and study it? And those small scale steps of change. And we'll be there to support you, work with you to talk through any issues or challenges right through to the end of the programme there. So yes. So you've got your problem statement. Sorry, that should read your aim statement. I'll fix that up before I send the slides out. So revisit your problem statement. Try and get it into 1 or 2 sentences that others would understand. Develop your aim statement, recognizing the fact that it's got to be smart. It's got to be people focused, people driven, as in it will motivate others to come with you on the change journey. Because when it comes to change doesn't necessarily lead to improvement, but improvement must have a change component. And then on the back of that, you could test out your aim statement. Is it robust? Is it specific, measurable, attainable? Because the reason is it's got to be something you can achieve. The achievable bit is critically important within your sphere of control. So just to remind you, if Jennifer and Heather, so in terms of the workshops, Katie's organised the CPD in relation to that, but tonight you could maybe think about reviewing performance and logging your hours there. So at that point, I'm going to leave you and say any issues, any queries, feel free to reach out to your practice development officer or alternatively Therese, who heads up that team. I'm going to leave you there to ponder and develop your aim.
Just remember, if you do need a hand with filling out anything, or you don't overthink it. Reach out to us and we'll more than happily give you a hand.
Fabulous. Thanks, Therese. And look forward to seeing you next week at next week's session. Thank you.
Thanks,
Bye.
everyone.
Cheers.
Bye.